Well, it really is an honor and a privilege to be here as a representative of the National Marrow Donor Program. As Dr. Sender pointed out, I left NMDP about 2.5 months ago after debating quite a bit, but ultimately it was made an offer I couldn't refuse, so here I am. What I'm going to show you today is some information from the NMDP that will give you an update about what's been going on there in terms of trends and give you a sense of the numbers of transplants that have been facilitated over the years and then most currently, and give you a little bit of information also about outcomes particularly important for this meeting for ALL. So I'm certainly happy to answer questions during the question and answer session if anything comes up. The mandatory disclosure. No conflicts of interest to declare. My current employment doesn't pertain to this material at all. A reminder, though, that PBSC and umbilical cord blood products are distributed by the NMDP under investigational new drug applications filed with the FDA. So what I'm going to talk to you about, as I mentioned, a little bit of background about the NMDP, some information about transplant activity as a whole and with ALL included, and then transplant outcomes over time that I hope will give you a little bit of perspective about what's been achieved in the realm of allotransplant in general and for ALL in particular. So just a little about the NMDP. It's a nonprofit 501c3 corporation. I think a lot of people have found the NMDP structure a little confusing, but it's a freestanding nonprofit. It's headquartered in Minneapolis and has over 900 employees, making it one of the largest nonprofits, certainly in Minnesota, and a $400 million annual budget. NMDP is contracted to operate the C.W. Bill Young cell transplantation program. This is a congressionally funded program that provides for cellular transplantation and really is the mechanism by which the National Bone Marrow Registry is maintained via a contractor, and that contractor is NMDP. There are 4 separate contracts, and they are the Bone Marrow Coordinating Center, the Cord Blood Coordinating Center, the Single Point of Access, Office of Patient Advocacy, and then the Stem Cell Transplant Outcomes Database, all of which are really important for the enterprise of undertaking allogeneic transplant in the U.S. The NMDP runs the first 3, and Medical College of Wisconsin actually runs the SCTOD contract, but in cooperation with NMDP. There's more information if you're really into government contracting at bloodcell.transplant.hrsa.gov. And all that, though, to say that NMDP is a contractor. So, and you'll probably see a lot of, certainly at Marrow drives, at donor drives, you'll see the Be the Match branding. And that's something that came about 4 or 5 years ago at NMDP and really was a reflection of the fact that we depend on the public. And I say we because I still feel like I'm a part of this organization. We depend on the public for goodwill and for their participation, without which we can't function. And so the NMDP name was always a little bit unwieldy and something that no one in the public could really often remember. So Be the Match was really the way to announce to the public what it is that we do. Sort of a dating service, but not exactly. We debated about that for a while. What do we do about that? It takes a village, as we all know, to make allotransplant, to make the care of these patients that we all take care of. It takes a village to make it all work. And it really is an amazing thing to see the amount of cooperation that goes on. I won't read this whole slide to you, but it just gives you a sense of the numbers of the different groups that participate in getting that product to you when you need an allotransplant, when it comes from someone other than a sibling in your own institution. It's really a vast network that includes a lot of international partners. And it's amazing that it really works. It really works well. So this is an update of where we are now with the numbers of donors that are available. As you can see, this has really grown and almost sort of toward exponential as we were getting into the late 2000s. There are now over 12 million donors registered with NMDP, and then there are about another 12 million in cooperative registries throughout the world. So roughly 22 to 24 million donors are out there signed up. For cord bloods, NMDP has access to 204,000 as of this year, and that is in addition to another about 350,000 units that are available internationally as well. So nearly 600,000 cord blood units are out there for patients in need. This slide just gives you a sense of what's happened with NMDP facilitated transplants over the years. In the year of inception, 1987, I think there were about 5. But as you can see, the growth, again, has really been just remarkable. And here you can see what sort of products have been delivered. And it's very interesting. You can see that there's been a trend downward for Marrow. And then in 2010, we had some data in adults that showed that Marrow was actually a little bit more favorable in the sense of less chronic graft versus host disease, so quality of life issues. Overall survival was exactly the same between PBSC and Marrow. But you can see that there has been a little uptick. And I know that in the pediatric world, of course, Marrow's always been, well, not always, but has typically been, at least certainly since the mid-2000s, has been the material of choice, of course. But in adults, we are starting to see that little bump. I don't think there's been any change in pediatrics, so that's primarily adult. One thing that's been interesting and not really clear why is the trend toward decreasing cord blood transplants. And as you can see, the banner year was 2012, and then in 2013 that number has fallen, and in 2014 that number has continued to fall. This may be a problem of cost and the burden of double cord blood transplant, where that alone can be $60,000 to $80,000 just for sourcing those units. So that is really one of those things that we're going to have to face as things move along. So this slide just gives you a sense of what sort of transplants have been done over time. And you can see that there's been, with the exception of CML, of course, from Gleevec's impact and the second and third generation TKIs, there's been a lot of growth in really everything for which allotransplant has been done, with the exception of ALL, where it's been a little bit flat. But certainly AML has grown dramatically. MDS has as well. And I think this is really a reflection of the fact that reduced intensity transplanting has become really pretty standard. People feel comfortable with it. And now older adults who primarily suffer from AML and MDS can be transplanted. If you look at what the trends have been by age, again, you still see growth in really every category. The teens are a little bit flat, but there has been continued growth in the young adult group and in kids as well. Certainly the area of hugest growth has been in the older adult. So I wanted to now shift to show you a little bit of information about outcomes, what's been happening with unrelated transplant in general. And I think that for those of you who are active transplanters, I don't think this will be too surprising. But maybe for some of the folks who don't do transplants regularly, I think that this information, I think, has not been necessarily well known, that things have really shifted toward improvement, a reflection of a variety of different reasons, not the least of which is better matching. So what I'll show you is an analysis that was conducted by the NMDP and the research arm of NMDP, which is called CIBMTR. The Center for International Blood and Marrow Transplant Research. These studies really resulted from part of the contract work that we did as NMDP and CIBMTR for HRSA, for the government, where they really want to see exactly how well the program is doing as a whole. And so this started really as a government report. Who knew a government report could actually be this interesting? But there you go. So this will show you some one-year survival rates for defined subsets of unrelated donor transplants. And all of these analyses have been done using statistical methods that have been developed at CIBMTR, really geared exactly toward transplant. So these analyses have been adjusted statistically for a variety of different factors that could impact, including race, age, gender, CMV status, performance status, and so on. So in this study, we looked at 3 different groups of patients to see what the trends have been over time. Those who were under 50 years of age with acute leukemia in remission and MDS, using myeloablative conditioning and from the interval of 1987 all the way up to 2011. A second group of interest is certainly the older patient group because that's become more commonly transplanted. So a separate study was done looking at the 50 to 69-year-olds with AML or ALL in remission MDS also. And in this case, non-myeloablative or reduced intensity conditioning from 95 to 2010. And then particularly for this group of interest, the age less than 20, AML, ALL in remission and non-malignant disease is included. And then umbilical cord blood only. So the question there was how are things going with umbilical cord blood transplants? These were all myeloablative and a shorter time interval just because of the fact that cord blood has only been used frequently in the past decade, so from 2000 to 2010. So in the adult group who received myeloablative conditioning, there were 7,130 patients. This is really, again, a reflection of the power of the registry, the ability to accumulate data on so many patients. The time interval of collection for the early years was grouped because there were so few. So in 1987 to 1990, there were 104 patients in that group, and then it was split out by year after that, where in 2010 there were 725 patients, so a pretty big group. Over the years, from 87 to 2010, there were an increased number of non-Caucasian recipients, so 8% to 31% in 2010. The age was increasing as we became more comfortable with myeloablative conditioning, and with a median from 19 to age 26, and then more patients with early risk disease were being transplanted. As word got out that it's really better to do transplant earlier if you think you're really going to have to go. So 26% and early on, 57% by 2010 had early risk disease. And transplant was happening sooner after diagnosis with a median of 22 months at the beginning of that time interval down to 8 months. So all things that NMDP has been favoring, earlier transplant, performed with earlier in time from diagnosis and earlier within the stage of their disease for better transplant outcomes. And this is what's happened in this group that I just showed you, the age less than 50, myeloablative acute leukemia. And I think that this is really quite remarkable and is indicative of how things have really improved. So here you see in the interval of 87 to 90, if you just plot this out on a line that accounts for some of the variability over the years, is roughly 35% 1-year adjusted survival in 1987 to 1990. And now if you look at 2010, that number is, it's a little hard diagonally there, but if you look at that number, it's close to 70%. So that's been almost a doubling, an absolute doubling of 1-year survival. We're not perfect there. We're not, as you all know, we're not there yet. But this is really a remarkable improvement in a relatively short span of time. And this represents a 9% increase year by year in terms of outcome. So I think that's pretty amazing. So now what about the age under 20 in cord blood transplant? Here we had 983 patients, all AML, ALL in CR or a non-malignant disease, all myeloablative, and it was either single or multiple cord blood units. There were 103 in the time interval lumped together from 2000 to 2004, all the way up to 206 cases in 2010. Again, there was a shift toward more non-Caucasian recipients, primarily here a reflection of the fact that cord blood fulfills the need for ethnic minorities better than any other source of stem cells. And here you see same idea with the line that's representative of the overall trend. And here the outcomes, it's a much shorter time interval, but have gone from about 60% to 70%. Again, an upward trend of about 8% per year. So continued improvement in the cord blood realm as well. So what about causes of death? I think this is also a fairly interesting statistic. The mortality spectrum has changed with advances in stem cell transplant technology and supportive care. And I think you'll see where, from these numbers, a little bit more about where we need to focus our attention. So for causes of death in the younger adult population, less than 50, myeloablative, in 1987 to 1990, about 14% of patients were dying of relapse, and about 54% were dying of complications of the transplant itself. However, in 2010, it's now about one-third. So there's been a shift toward an increased number, not an increased number of deaths per se, actually fewer deaths, but those deaths that have occurred, the proportion is now more toward relapse and less toward complications of the transplant. Although, again, there's still need for progress in both of those areas. In the 50 to 69-year-old group with non-myeloablative conditioning, in 95 to 2002, recurrent disease was about a quarter. Complications were about 41% of deaths. In 2010, that has shifted fairly dramatically, where nearly half of the deaths that occur are a result of relapse. So really, I think what that tells us is that relapse has been, now that we're better at doing transplant, we still have an issue with trying to figure out how to get rid of the disease. Now, complications are about a quarter of the deaths in that older population group. So a reflection of the increased safety and the ability to do a transplant with reduced intensity conditioning. So what I've just showed you now is the NMDP is the world's largest registry of unrelated adult volunteer donors and cord blood units. The expectation for 2014 is there will be more than 6,500 transplants facilitated, and that includes transplants that occur internationally using U.S. donors, and of course, transplants that occur in the U.S. using both domestic and international donors. Most adult donors, as you saw, are asked to donate peripheral blood stem cells in contrast to marrow, although that trend is shifting a little bit. And for transplant recipients, survival rates have improved consistently over time. So now I want to shift a little bit of attention toward the CIBMTR. As I mentioned, this is a collaboration between the Medical College of Wisconsin and NMDP. It was created in 2004 with a merger of NMDP's research section and the IBMTR, the International Bone Marrow Transplant Registry, which was centered at Medical College of Wisconsin. As I mentioned, MCW holds the contract for the SCTOD, which mandates reporting of all allo transplants in the U.S. that occur annually. It's probably a little burdensome. It's more than probably. It is burdensome for transplant centers. We recognize that. But the richness of data, the ability to go back and understand what's happening in the world of transplant certainly is a huge asset of that burden. It's also worth noting that autologous transplants are reported, but they're voluntarily reported as opposed to the mandatory reporting for allotransplants. So autologous transplant reporting is not complete in terms of all the centers where there's a lot of activity, but pretty good. And actually, there's still lots and lots of auto cases to look at if there are questions that arise about auto. The observational database contains more than 350,000 transplants that have been acquired since 1974. And this has been an incredibly productive effort, this collaboration, with many high-impact papers that have been published in the field of BMT. And it's worth noting that for younger investigators, this is a really wonderful way, certainly one of the ways that I became involved in clinical research. But anyone can make a proposal for a protocol to look back at the data in CIBMTR with a question. And the beauty of it is all the power, the statistical time, and there's typically lots of patients to look at. So it's really, if one of your younger faculty members has a good idea, that would be an appropriate retrospective study using the registry data. All you have to do is propose it at the tandem meeting. And it can take a little while to happen, but it really is an amazing resource that it doesn't cost your institution anything. So the CIBMTR collects data from a variety of different transplant centers throughout the US and internationally, including in Europe and South America, India, China, Japan, Australia, even a couple of centers in South Africa. So it's really well pretty well represented throughout the world. This slide just tells you a little bit about transplant activity in the U.S. and, of course, that huge bump up and then drop in autologous transplant in the late 90s is breast cancer and then the demise of that particular mode of therapy. But you continue to see now that there's been a continued upslope again, and a lot of this activity is now myeloma. So what about what sort of stem cell sources are used by recipient age? So in the younger age group, as you can see that there has been a change, a little bit of a change in what the stem cell sources have been. This is proportional. So the bone marrow has held fairly steady, but over time there's been a small increase proportionally in the number of cord blood units used, and a slight decrease in the number of peripheral blood stem cells. In the adult population, it's been really pretty consistently the use of peripheral blood stem cells with a tiny bit more cord, shift toward cord. What are the indications for transplant? And these are the latest data we have from 2011. As you can see, based on auto versus allo, for auto, vast majority are multiple myeloma, followed by non-Hodgkin, and then other cancers, and this is a variety of different things, including neuroblastoma. And then for allogeneic transplant, the leading indication is AML, followed by ALL and MDS and non-Hodgkin lymphoma. So focusing in on the younger patients, here you see the indications for transplant for age less than 20. And as you can see that for auto, the number of transplants done for other cancers, this is, I think, primarily neuroblastoma. ALL and AML here, a little more ALL because of the younger population. And then other non-malignant diseases, the variety of different things that can be benefited from allotransplant. So what about allotransplants for age less than 20 in terms of the trends over time, related versus unrelated, peripheral blood versus unrelated? And as you can see that with time, as the donor registry has improved in terms of the numbers of potential matches, there's been a shift downward proportionally, or been a shift downward in the number of related marrows that have been done. And then you'll see that the number of cord blood transplants has increased over time. And again, a reflection of the improvement in the number of cord blood units and more comfort with cord blood transplants. So unrelated donor stem cell sources by age, again, divided into the younger versus older over time. And here you see marrow, again, slightly falling, and the number of cord bloods going up. Again, this is proportional. So what's happened with 1 year survival by year? So if you look at the outcomes for HLA matched siblings, sort of the gold standard, if you will, that has improved. This is the age less than 50 group, HLA matched siblings, a little over 60% here, and now up to about 80. So these are the best possible matches in the younger population group. But this trend of improvement, again, has continued with unrelated donors here in the less than 50-year group, and also even in the older population, too, that, again, very much reflecting the similar, what I showed you overall for transplant. So these trends continue in all of these different settings. So what about the number of reduced intensity transplants, since that's become now one of the more important modalities for, particularly for older adults? As you can see, though, for ALL, the numbers of reduced intensity transplants has grown, but not dramatically, not too surprisingly. I think most people don't feel too comfortable using a reduced intensity transplant for ALL. That trend has dramatically gone up for diseases like CLL, where the majority of transplants that are done for CLL now are reduced intensity, as opposed to the earlier days where nothing was, of course. So what's the effect of a related versus unrelated donor being used in ALL in younger patients? So this graph shows you the survival after ALL identical sibling transplant from 2001 to 2011. So this is divided by disease state. So early means CR1, intermediate means CR2 or later, and advanced means not in remission at the time of transplant. And this is one of the things we've tried to emphasize through our networks to referring physicians that earlier transplant clearly results in better outcomes. Some of that, of course, is a reflection of the disease itself, but some of it's not. And what I'm going to do is just show you what happens when you do the same transplants but using an unrelated donor. And here you see, we don't have a graph that shows them overlaid, but as you can see, the outcomes are actually fairly similar. Keep in mind that this time interval includes a time where matching was not as good as it is now. So as you can see, though, things are getting pretty close to being the same between unrelated and related donors. That's really the point of this. Now, what about the effect of age? So age less than 20 versus age greater than 20 in related allo. So all related allo, all ALL, and the only difference here is whether they were less than 20 or older than 20. So this is the, and these are all HLA identical siblings, taking out the HLA matching issue. And here you see the outcomes for age less than 20, again, that decade of the 2000s, and by disease status. So for early transplant, presumably all of these early transplants, or the vast majority, were for patients with CR1 but high-risk disease, otherwise they wouldn't have gone to transplant. And then if you look at the outcomes for patients who are older than 20, you can see that it's not good to get older and have ALL. Unfortunately, not a lot you can do about that. We're still working on this, but there is clearly a significant impact of age. So just to give you a sense again, particularly if you look at the early group here, so this is about 60% or so, almost 70 actually. And then when you just add the age in, the outcomes drop to a little over 40%. So what about unrelated donor transplants? So if you have to use an unrelated donor in older patients, this is what you would expect. But this is not dramatic. This is in the older population. So, but this isn't dramatically different from what I just showed you for related donors. So again, suggesting that the unrelated donor, well-matched unrelated donors are more or less equivalent to well-matched siblings. So in conclusion, allotransplant continues to improve over time with better HLA matching for unrelated donors, with better supportive care, and the innovation of reduced intensity conditioning and other improvements. NMDP and CIBMTR are together a powerful force for increasing knowledge in the field and increasing the careers of younger investigators through CIBMTR's programs, and increasing adult donor and cord blood resources improve the chances that an appropriately matched donor can be identified. Still dependent on ethnicity, so right now with cord, with a 9 out of 10 or 10 out of 10 adult donor match, or a 4 out of 6 cord, for Caucasians that number is about 93% of a source can be identified. For African Americans, the biggest group for which there is a challenge, the group for which there's the biggest challenge, that number is about 66% when you look at combining cord and adult donor resources. And allogeneic transplant for ALL remains a critical tool for patients with high-risk disease at diagnosis or for relapse disease. And as I've shown you, I think with a well-matched unrelated donor, we can achieve outcomes that are fairly similar to that achievable with a related donor. So with that, I will conclude, and thank you very much.